Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
Dr. Miquel is one of the most charming doctors that I've had on my radio show recently. And it's, I always see someone like that and I say, oh, well, he probably isn't, he's not so nice or he's not so smart. But that wasn't true. And I met Dr. Miquel when we were doing sensitivity training. And he was so attentive. And Dr. Miquel, a lot of times I do this, and it's usually the doctors that don't pay attention. And they need it more than anyone because they know medicine, but a lot of times they don't know what happens with the people, even though you have a natural ability. So we do welcome you. We're happy that you're associated with MCCI. And so what's going on with your life today?
Well, thank you. Yeah, no, it's good. I'm happy to be back, and I want to thank you for having me back. I had a great time the first time we did this, and I'm looking forward to doing this a lot more in the future. Things are great. Just working, going through the routine, trying to make sure the family's doing well. I actually finally got a chance to go on a belated honeymoon with my wife, so we just got back from that.
And of course, you didn't take the children.
We did not take the children.
And where did you go?
We went to Spain. And got to go back to our roots. And also visit where my father went to medical school, I don't even know how many years ago, 40-something years ago. So it was nice. We had a great time.
Well, that's very important because you work very hard every day. And I heard when you were telling me about your father when we were in your office that he was very special to you.
He was, yeah. He was everything you can expect in a father. He was a very hard worker. He loved his job. But most importantly, he loved his family. And no matter how busy he was, he always made sure that there was time for family first, and then he took care of everything else afterwards.
As a family physician, and knowing how you care so much about families, I have felt, and I don't know how you feel, I do know how you feel, I know you enough, that when somebody is sick and they come to you, and they're alone, and they don't have a family, compared to another person who comes, they have their family there, and they're watching over. That's a different kind of medicine, isn't it?
It sure is. We like to pride ourselves in the relationship we have with our patients. I think as a family physician, we have a very specialized type of care, which a huge part of it has to do with the relationship we're able to form or the bond we're able to form with our patients. And like you alluded to, a lot of patients are lonely, and sometimes the only time they'll get out during that month or during that week will be to come to the doctor. So they get dressed up, and it's almost like a social visit for them more than it is a medical visit or to have blood work done. They just enjoy getting out of the house, and they don't get a chance to do that too often. So we have to treat the person as a whole, and they're not just a list of lab values or pages of x-rays and CAT scans. They're an individual, and until you get to know that person and most importantly, gain their trust, you're never really able to treat them fully, regardless of what the numbers say.
I was thinking about my mother because I think I mentioned this in the sensitivity training that she would complain she had this and that, but when I went with her to the doctor and I was waiting for her list, he said, "Well, how are you doing, Mrs. Sprung?" She said, "Oh, I feel great." I said, "Mother, what about these things?" "Oh, no, I'm doing fine." What is that?
Yeah, we see that quite often, and I think a lot of times people that are lonely at any age have too much time to think about things. And when you are by yourself and you have too much time to think about things, you can have a tendency to maybe blow some things out of proportion or give it a little too much importance, and then it just becomes a bigger problem than it really is. So when people can get distracted or they can be entertained, they tend to forget about their problems, or they'll forget about the things that are bothering them, as long as they're not too severe. I mean, obviously, if something big is going on, they will remember and they will bring it up. But we've had that quite a few times in our office where a patient will come in, that they'll actually call a few times before they come in with multiple complaints, come into the office, and everything is fine. So we enjoy seeing that. We know that it's important to them just to be seen and just to be around other people, and we enjoy having them at the office. So
I'll tell you about, when you're talking about lonesome, I heard from my staff member, Leonie, this morning. She said she came to the office, and we always have a little rack of magazines on the outside, and there was a woman sitting on our little bench reading a magazine. It was like 9 o'clock in the morning. She said, may I help you? She said, no. She said, may I sit here? She said, I love the magazine. She said, but I'm waiting for the senior center, which is across the street, to open. She said, because I don't have a car and I have no other way to get there. So I had to get here early. Someone drove me. And she was waiting so that there's some entertainment that's going to happen.
Yeah, and again, people just like to be around. And unfortunately, sometimes they don't have control of their transportation. So they'll be dependent on buses or taxis or the Palm Trans, Connect, and all these different forms of transportation, which are not necessarily going to show up and drop them off at the time of their appointment or the time place is open. And we had to make adjustments at our office because those are things that you kind of learn on the fly, where if we closed for lunch, we were closing the front door for a certain time period, and we stopped doing that a while ago because we realized some of the dependent patients needed to be dropped off earlier for whatever reason, and we didn't want them standing outside. So we would leave the waiting room open and at least have some reading material and maybe some coffee there.
That's very, very thoughtful, very nice of you. Yeah. Now, of course, in your medical practice, you're with this great organization, MCCI, and they're so good, and you just now have expanded. And so, I mean, you were so pleased to show me around and everything, and you have some, let me tell you what I was impressed with. When you go to a doctor's office, you know, the first thing they want you to do is sit on this bed, whatever it is. And yet you have the most up-to-date, modern, do we call them beds? What do we call them?
They're exam tables.
The exam tables,
but,
okay. They sound like you sit on it. But.
Right, yeah. I guess they are more exam beds than anything. First of all, it is an honor and a privilege to be working for a company like MCCI. They are very detail-oriented. They're very great people. At least the administration that I've come to know, and Barbara and Cindy, have done a fantastic job. But we expanded our office. We have added 4 new exam rooms with a possible 5th, a new office, a new break room, a new nurse's station. And we did update all the instruments and the exam tables. These particular tables do not have the step where you actually have to pull it out from the bottom, have somebody awkwardly try to stand and turn around on it to sit down on the table. These in particular tables are electronically controlled, where they go up and down by themselves, and we can drop them almost all the way down to the floor, so it's a lot easier for a person to just sit on it, and they don't have to worry about struggling and tripping over a step to get up on the table. Another thing they did was they took the scales where they weigh the patients, and they recessed the floor so that the scale is actually at floor level, so you don't have to step up onto the scale. And things like that are very important because you may not think about it, but they are risk factors, and they are potential hazards for patients who have trouble standing up or keeping their balance.
Well, it's like why the ADA, you know, that's been a long time coming. I mean, years ago, let's see, it was back in the 70s, I think, when I was in Minneapolis, and there was a woman who lived in an iron lung for many years, and she could only move her head with a stick in her mouth. I think I described all that to you at one point. And she made a difference. She was typing with the stick in her mouth to get the buses to be able to have lifts so that people could still get around. People don't realize that if you make it easier for them, they can remain a human being.
Oh, absolutely. It's things that are overlooked because we take things for granted. When you look at the majority of the general population, I guess most people may not have trouble doing certain things, so you don't think about it. You just go through the motions. But when you take time to just sit back and look at things as a whole and start to take into consideration what other people may have to go through, that's when people, maybe much smarter than I am, will come up with these brilliant ideas, which seem so simple, but make all the difference in the world. Yeah,
well, as a physician, I don't know what they taught you in medical school, but that probably wasn't one of the things because you had so much to learn.
Yeah, no. Well, there's just so much that they try to teach you. Unfortunately, it is a lot of theory. It is a lot of hands-on examination stuff. So how to manage an office, how to treat people, how to weigh people or how to set your office up is not something that you learn anywhere through the process. You learn through life experiences.
Yeah.
And that's where you learn most of your stuff. And the
Yeah.
same is true with medicine. So
Yeah, I think that's very good. Yeah, you're absolutely right. Well, I think that your article was very good. Why don't you tell people, I hate to do it because, let's see, the article will probably come out in another week. Well, that's right. You can tell them a little bit about it ahead of time. I know you like to write. And tell me why you thought about this particular idea.
I decided to write an article entitled How, Why, When, Where, to try to bring to light the different types of screening tests. I'm very passionate about preventative medicine. I'm very interested in having people stay as healthy as possible for as long as possible. So I wrote the article basically touching base on the different types of screening tests that we have. I thought about it because on a daily basis, multiple times a day, patients are asking me when I should have this test done, when can I stop doing this test, which is even the more important question to a lot of people after they've passed a certain age, because they get a little tired of doing the same test over and over again, especially if it's been normal. So I tried to fit in a small space a lot of information, but basically to try to educate the people about when they should be doing certain tests, why they should do certain tests, and then ultimately when they can stop doing certain tests.
Well, we have time, and this is good because the radio is supposed to complement your articles anyway. Let's talk about some of the screening. What screening do you think is probably the most important for an older adult?
Well,
It's hard to choose, but
it's so difficult because we do have screening tests which are for cancer, preventative for cancer, such as the colonoscopy, the mammogram for women, checking the prostate in men. All of those are very important. I think going back to my previous talk, I think one of the most important screening tools that we can use is one for depression, which we don't use all the time. And I think we get too caught up with thinking of screening tests as a cancer preventative type thing, which I almost to an error limited it to in this particular article, although I do plan on writing more articles in the near future, expanding on some of this. But there are screening tests for certain diseases, and depression and alcohol or drug use in our adult population above 65 is a very serious and real problem. So as far as what's most important really depends on each individual patient, because for some people with family histories or some people with certain risk factors, it's more important to gear their screening test towards what they're most likely to develop.
So when you say risk factors, that's why we always have to fill out what our mother, did any of our parents have heart failure or cancer, because is that really important?
Absolutely. A lot of the medical conditions that we will come across on a daily basis, or that we will have as a person, are genetic, and they are passed on from parent to child and from generation to generation. So a lot of these cancers or a lot of disease processes are passed on in your genes, and we cannot control our genetic makeup yet. I guess and when we live in the Star Wars or in the future, we'll be able to do maybe some of that. But for now, the only thing we can control are our environmental factors. And those are the things that I don't believe we do a very good job of as individuals, but it is becoming more popular, and it is being talked about a little bit more in the public.
So in other words, if someone comes into you and they're fine, but they have certain risk factors because of their family, hereditary, then you check that more often, or you make sure they're screened, or what else? I guess you have a big discussion with them that you better be careful about this, and this,
sure.
Right?
Yeah, I think in general, there are recommended screening tests that we do for cancer for everybody. The colonoscopy for men and women, mammograms for women, pap smears for women, prostate tests for men are all supposed to be done for everybody. You don't just pick and choose necessarily who's going to get those. Those are recommended for everybody. So even when you feel like you're doing well or you have no symptoms, is the time to do it, because when you start to feel something, it's usually because that particular disease process is already too developed or too far along, and it's more difficult to treat. It's funny you brought up the papers you fill out when you come to the office, because risk factors, it is very important. A lot of the questions seem relatively insignificant to most people, or silly, such as what job do you do, or did you do what your religion is. We don't ask those questions because we're nosy. We ask those questions because certain religions will not eat certain foods, or certain jobs will expose you to certain chemicals or to smoke or to different potential risk factors. So all of those questions are very important to us as physicians to try to have as much information as possible to be able to treat that particular person the best way we can.
So when you come in to meet a new person and they fill this out, you have to take a little time to look at that, don't you?
I ideally, yes, but I do not look at the paper because I just ask all the questions over again
Really?
when the patient comes in the room. I don't know if you want to call it laziness or if I don't trust what's on the paper, but I feel like when you actually ask a person, sometimes you'll get a little bit more than what is written on the paper, and I don't want to just leave it to what's written down. I want to try to, and it's a way for me to get to know the patient. It's more personalized for me to be able to talk to the patient. I think they feel a little more comfortable when they're talking about things that aren't medicine involved, and that way I can start to establish a relationship with them.
I think it's a good idea because sometimes, I have to go check something and I said, well, that's not really the whole case, but that's all right. I'll leave it because I just want to get rid of it, right?
Yeah.
But if you then pick up on it, then you can say, well, what about that, right?
Well, then there's limited space, and a lot of times it's
right.
just check boxes, and they'll just go through it quick, and they'll put down everything they remember. But then when you ask them, has anybody in your family had any medical problems? They say, oh, my mom had diabetes. And I'll say, okay, and that's what's on the paper. And then you start delving a little further in. Oh, but how about your grandparents? Or is there any history of cancer? And they're like, well, there was that aunt on my dad's side who had colon cancer and died at a young age. Or
And wait. So an aunt on your father's side still has that bears watching?
Yeah,
Really?
yeah. I mean, your father's sister is carrying the same genes that your father does. So just because your father hasn't manifested any kind of particular diseases or have developed any cancer, if his sister did, you're still at risk for having that as well, because that all comes from your grandparents. So any kind of direct uncles, your brothers, obviously, sisters, your parents, grandparents.
But
those
let's
things
say
all are,
that one of your I know we're really getting into this. That's so interesting. But let's say that one of the people who died of a heart attack smoked. They were very overweight. Do you take that into consideration?
You do. You take that in consideration, and you can say maybe that individual was a product of his circumstances or environmental factors. Yeah. So though maybe he didn't control his environmental factors, but there's still a part of him that had a genetic predisposition to develop these things if he smoked, if he gained weight or her gained weight. So that patient is also at risk if they have those similar risk factors, because the genetic part is still there. We can't explain some things why people who smoke their whole lives never
we
get
say,
cancer.
well, someone smoked from 95 and nothing happened, right?
Yeah, and then people who don't smoke will get lung cancer. So
Exactly.
there's certain things that we
so
can't control, but the environmental factors are very important. Ultimately, the genetic makeup is what you are and what you are going to be.
I have to, I always get so involved with your talking, I forget to tell people who you are again. Dr. Alejandro Miquel, and he is a family medicine doctor in Palm Springs, Florida. He's affiliated with JFK Medical Center, but the most important thing that he's part of the MCCI medical group. If you want to call him for an appointment, it's 561-967-0234. That's 967-0234. And in this, I don't want to forget to talk about Lisbetti, because every doctor needs a Lisbetti.
That is very true.
She's his assistant and runs the office, and it's just such a pleasure. So I know that's important. I have a question about screening. And of course, you're young in a sense, but years and years ago, screening was what doctors hoped for. It had to come from the pharmaceutical companies, I guess. How does that all work? How does that come to pass?
There is such a multitude of mental giants that get together on different levels to formulate these screening recommendations. And unfortunately for us, well, unfortunately for everybody, but we're the ones left to decipher it. there are multiple agencies that come out with the recommendations. So you'll have the American Urologic Association will come out with their recommendations for prostate screening, and then you have the United States Preventative Service Task Force comes out with their recommendations for prostate screening, and sometimes they don't line up, where they don't see eye to eye. So you have to do what's best for your patient, and they're pretty similar. The American College of Gynecology and Obstetrics, or ACOG, they come out with their screening tests for mammograms and for pap smears. And again, the United States Preventive Service Task Force also comes out with their separate recommendations. So you have a lot of organizations and a lot of really smart people that get together and try to calculate risk, life expectancy, and cost of healthcare. So all of that goes into try to determining when to start, what to do, and when to stop.
Are there screenings for children? I know that you're a family practitioner and don't you handle mostly older adults?
We do in our practice, yeah, but we certainly trained in pediatrics.
So are there screening tests for children?
There are. Starting from birth, there's a lot of screening tests for genetic diseases, such as cystic fibrosis and stuff like that. Kids will be screened for anemias, and depending on what their background is or what their basically their risk factors, also their family histories and what happened intrautero, if the mother got involved in certain things or certain toxins or drinking, or, some of those things can predispose you to having problems. So kids will be screened for certain things, but different than what the adults are screened for. And children, at least school-age children who are going to be participating in sports or be active, need to be screened for heart disease. We see it too often where a kid will just, unfortunately, just drop dead, have sudden cardiac arrest, and they'll just drop dead while they're playing a sport. And they don't do enough to screen them in their pre-sports physicals. So that's something that probably needs to be brought to light a little bit more. But it's different. Children are expected or not expected, but it's assumed that they are going to be healthy. I guess the natural thought process is you're born healthy, and then as we get older, things start happening to us. And many patients have told me to not get old and have warned me about getting old, and I don't know if I can do anything about it, but we're looking into it.
Oh, no. Well, of course, it's funny, and I know you're going to agree with this, and I really believe this, that when a person is a certain way when you see them as they're older, they're really that way when they were younger. Don't you find that? I mean, it doesn't really change.
No, yeah.
People have the same personality,
absolutely.
Don't they?
Yeah, I think so. I think maybe depending on the person, as we get older, you may be a little more uninhibited. Maybe you're a little more prone to say or be more vocal about things. But yeah, personalities don't change. I don't think they do.
And I bring that up because there are people that complain about certain people. They go to a nursing home and they say, "Oh, that person just sits there and has no friends. And they just sit there and then no one comes to visit." And I always say, well, if you looked at them younger, I think that's the way they were. They probably stayed at home. They probably read a book. They probably didn't make friends, and they and their family didn't get together.
I think that's very true. And unfortunately, a lot of times in homes, nursing facilities, assisted living facilities, people are not there necessarily because they want to be there. I think a lot of people, as you alluded to earlier, are lonely, and maybe they've lost people close to them pretty recently, and they're still grieving, or they may be depressed a little bit, and it certainly changes how they are. So people will get a bad rap because they'll be seen as the grumpy old man or grumpy old woman, right. Where maybe 20 years before that, they were the type to go out and enjoy a night out with the friends and always laughing. But when you've lost everybody around you and have nobody around to talk with, you're just you don't change who you are. You just don't feel like you are who you were anymore.
Yeah, right. That's so well said, Dr. Miquel. Let's go into some things that I know, there are probably tests too for this, but when you've had a patient for a while and you see them, you probably can, and that's why you like to talk to them, of course, if they are depressed or if you notice a little bit of cognitive changes. So how do you deal? You make notes, and what do you do about that?
Well, I try to be as upfront with all of my patients as possible. So I'll ask them if they feel like things have changed recently. Are they doing certain things less than they used to? Do they feel like they're sleeping more than they did before, or less? Or is their appetite changed? A lot of those things are clues as to if somebody's depressed or not. You'd be surprised that if you just ask somebody the answers you'll get. And a lot of times they're going to tell you. They've done a lot of studies, and I think 85% of diagnoses are made in the history and physical, and you don't even have to order tests or imaging. So just talking to somebody gives you everything. For cognitive dysfunction and the beginnings of dementia or memory issues, unfortunately, it's going to be the family that notices it before the patient does or the individual does. So it helps when you have somebody in the family with them during the visit, because they will pick up on those things before the individual does.
So you really encourage families to come with their elders or somebody?
As long as the elder feels comfortable doing it. I don't like to have anybody feel uncomfortable in the room. But if they do feel comfortable having somebody they trust with them, I strongly encourage it, because you get a lot more information from somebody who's close to them when there's open dialogue and you're just able to talk about it.
Have you ever had the responsibility of telling someone that they have to give up their car?
I have. Unfortunately, there's a lot of things about our profession that are not very pleasant. And on the grand scheme of things, I guess this may not be as severe as maybe telling somebody they have cancer, or telling somebody that they don't have long to live, or they have. But it's tough when you're taking away somebody's car. You're taking away their livelihood, and it's not the easiest thing to do. But I have had to do it, and I've had patients resistant to do it, where I've unfortunately had to go around them and write a letter to the DMV and to the states to have their license revoked. But it's in the best interest of the individual, and it's in the best interest of the general population that we do those things.
Okay, well, this has been great. I want to tell everybody you've been listening to Dr. Alejandro Miquel, and he's a family medicine doctor in Palm Springs in Florida. And not Palm Springs, California, Palm Springs, Florida. And he's with MCCI Medical Group. You can call him at 561-967-0234. Thank you, Dr. Miquel.
Thank you.